in US or India?
No. I came in the morning only, early morning, and joined back.
If you are okay, join. Otherwise, no need.
Okay. I'm joined, so I'll listen to it.
Sure.
So best
Thank you.
wishes for your Niha. You have started this medical CMEs now, hai na?
Yes.
Good.
Welcome. Thank you for accepting our invitation.
Thank you. You're welcome.
Thank you, Dr. Upma. Okay. Yes, Karpahambal, you can start.
Yes. Good evening, everyone. A warm welcome to one and all for this new series called as Vivadham. We know change is the only constant thing in the world, and medical evolution is happening on a daily basis. How one treatment scores over the other, and there are pros and cons of each and every treatment, and what will be the way forward. Hereafter, for the next 12 months, we are going to have a nice series of different treatment modalities for each and every topic in obstetrics and gynecology and fertility, including all the subspecialties. So this episode, the first episode, we are going to start this episode on the most important thing called as Partogram, which is our daily bread and butter. So which we do on a daily basis. Next slide. Now, our medical education committee of OXY is actually a very dynamic committee. We've proposed to have one always. Sampath Kumari Madam is the president of OXY. Dr. Vijaya is the chairperson, and I'm the co-chairperson of the medical education committee of OXY. Dr. Vijaya is a HOD and professor of ESI Medical College and Hospital, as a renowned teacher and a very dynamic past president of OXY. Next slide. Now, I welcome Dr. Sampath Kumari Madam, who is the president of OXY, who is a well-known person all over the country and across the globe, to give the welcome address.
Good evening to all. I welcome you all for this Vivadham series. As Dr. Karpagambal was telling, we will have a different, what was we are doing previously and now what we are doing in future, how it will go. For that, we have a moderator. Today, we have Dr. Mahalakshmi. She will be talking on Partogram, which is followed in her college, and Dr. Rekha will be talking about the labor care guide, which is followed in Safdarjung Hospital, Delhi. And with this, all of us will be knowing labor care guide. Master is Dr. Muralidhar Pai. He is the dean in Shillong Manipal's hospital. So he will be moderating why Partogram is followed and why labor care guide is not followed in every places. What are all the advantage with that, and what is the advantage with the labor care guide, and how others can also follow the labor care guide. The aim is this only. For a topic, we will have the previous, present, and the future. So this is our idea. For this, we have the coordinators, Dr. Vijaya and the Dr. Karpagambal. We will start with a prayer and go to the scientific section. Thank you.
Shubham Kurutvam Kalyanam Arogyam Dhanasampadah Shatru Buddhi Vinashaya Deepajyotir Namostute Deepajyotir Namostute Shubham Kurutvam Kalyanam Arogyam Dhanasampadah.
Now, I request our Secretary of OXY, Dr. Meena Mahalingam, to render the OXY prayer.
1 minute. OXY prayer.
Thank you, God. In humility we gather. In gratitude we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn. The courage to deal with it all when things are not perfect, and to remember that we are but messengers. To keep our women safe and free from sorrow, we bow before your kindness and the magnanimity of your endless love. Over to you, Karpagam, for the...
Thank you, Dr. Meena. Now we'll move on to the session, the most important one. Now I welcome Dr. Mahalakshmi, who is a senior assistant professor at ISO Government KGH Hospital, Madras Medical College. She is going to talk about the time-tested, age-old Partogram, the pros and cons. Over to you, Dr. Mahalakshmi.
1 minute. We welcome Dr. Muralidhar Pai, sir. Hope he has joined.
sir.
Welcome, sir.
Good evening, sir.
Thank you.
Good evening, sir.
Thank you
Good
very
evening.
much.
Yes.
Welcome, sir.
Dr. Mahalakshmi, 15 minutes time, all yours.
Good evening to one and all present here. My topic for today is Partogram, its pros and cons. So as we all know, it is a graphical representation or a graphical overview of labor. It aims to assess the labor progress in order to enhance the management, and it is accessible and available in a pre-printed paper version. So it is easy to use, and it includes not only the labor progression, but also includes observation on maternal and fetal conditions as well. And the term partograph or partogram, whatever, it can be used interchangeably. And now let's see how the partograph was born in a short, So the Friedman curve, which represents the basis for presenting the labor progression graphically, was born in June 11, 1952. In 1954, Friedman presented a graphical analysis of labor, including the first 100 women in a series of cases studied. So the cervical dilatations were recorded in centimeters per hour throughout labor for the participants who were all primi gravida at term, admitted to the hospital early in labor. The results formed a curve that became known as the cervicograph, also known as the Friedman curve. In 1955, he again published a second paper on labor progression, including 500 women. This time, he made an attempt to define the limits of normal primiparous labor by establishing a mean labor curve on the basis of statistical deviations from the mean cervical dilatation time curve. So based on the cervicograph derived from Friedman's work, Philpott, he developed the partograph. The partograph was intended initially to increase the efficacy of midwives in an African labor clinic as there was lack of access of medical doctors. So aim of the use of partograph was to identify the abnormal progress of labor. Apart from monitoring of cervical dilatation, the partograph included observations of necessary intrapartum details. After a prospective study of 624 Zimbabwean primi gravida, an alert line to detect the abnormal labor was added to the partograph. The main aim of including an alert line to the partograph was to identify abnormal progress of labor and enable early transfer of women with slow progress. The alert line was found to be useful if it was applied at a cervical dilatation beyond 3 centimeters. Philpott found that almost 11% of the included women in this study crossed the action line and concluded that identifying women crossing the action line allowed proper management of labor and reduced the risk of cesarean section, incidence of prolonged labor, and perinatal mortality rate. Slide move on. Sorry. So in 1954, Friedman introduced the first graphical representation of cervical dilatation. In 1970s, development by WHO, the World Health Organization, adapted and simplified the concept into the partograph. And in 1987, WHO partograph standardized and published a standardized partograph with alert and action line to guide timely intervention. In 2000, modified partograph was introduced. And in recent years, we have digital partograph, electronic and app-based versions, which enhances the accuracy, ease of use, and integration with the patient record as well. As we all know, it has 3 components. Part 1, the topmost, is the fetal condition. Second part is the progress of labor, which is the middle component. And the third one is the recording of the maternal condition, which is at the bottom of the partograph. So this image, you can see the topmost portion, it has the maternal information. The second one is the fetal well-being, which is represented as a chart, that is the fetal heart rate. And below that is the character or the color of the light curve. And below that will be the degree of molding of the fetal head. And the middle portion is the labor progress, where we mark the cervical dilatation, the descent of the presenting part, and the uterine contractions once in 10 minutes, and how many contractions we get in 10 minutes. And below that is the column for medications, whatever we give, like oxytocin, or if we give pethidine for pain relief. And below that will be the maternal well-being, where we record the blood pressure, pulse, temperature, and urine, albumin, glucose, and acetone whenever she voids urine, and also we record the urine output. Now, even though the partograph was initially developed for use in developing countries and rural settings, Now it is being used in each and every center where we conduct labor. So now let's see first the pros of using the Partogram. It provides a pictorial presentation of labor. You can see on the right side, I've displayed the image of a Partogram, which is progressed. This woman has progressed normally and delivered vaginally. You can see the dilatation. It falls on the alert line, and you can see the descent of the presenting part as well, and how adequate she has got the contractions. So it shows the pictorial representation of a well-progressed labor. So good overview of the labor progression, assessment of cervical dilatation, including the descent of the presenting part, strength and duration of uterine contractions. Fetal and maternal conditions are also being documented in the Partograph. Again, it is accessible for most healthcare workers in maternity care because it comes in paper form, and it is a useful handover tool. When the shift changes, it's very easy to give handover, and it promotes continuity of care. And again, it is a tool for teaching the students and midwives about the labor progress. So you can store as records, and we can show the abnormal labor progress. And you can see in this on the left side, here the uterine contractions are inadequate, and they have given the oxytocin infusion. She has got adequate uterine contractions, and then she progressed and delivered normally. So oxytocin infusion was started once the cervical dilatation crossed the alert line. On the right side image, you can see the woman has had an obstructed labor. So where the cervical dilatation has crossed the alert line and the descent of the presenting part has crossed the action line as well, and has ended up in the cesarean section. So it helps in early identification of prolonged labor, need for augmentation of labor, or termination of labor by cesarean section. And some studies also suggest that it has resulted in shorter labor duration, reduced cesarean section rates, and fewer neonatal admissions, and better maternal and fetal outcome, especially in a low-resource setting. It is a simple, inexpensive method which is suitable for under-resourced settings where continuous monitoring is not feasible. It enhances quality and regularity of observation. It increases the frequency and quality of maternal and fetal monitoring during labor, and it is found to be more user-friendly, improving compliance and outcomes compared to composite versions. It serves as a document for communication during handover in labor management, as I said earlier, and use of Partograph may reduce the number of vaginal examinations and unnecessary interventions. Now, having seen the endless advantages of using the Partograph, now let's see the limitations of Partograph. So to use the Partograph as intended to identify risk and act, one is reliant on skilled midwives and obstetricians with no knowledge to use the tool and capacity to act in accordance with the required interventions. In a review of qualitative evidence, birth attendants in low-resource settings reported inadequate training in using the Partograph. So this has led to lack of confidence in using the tool. And retrospective completion of Partograph due to fear of litigation has also been reported. And it is used incorrectly in many settings, but even if it's used correctly, they report challenges in initiating proper labor management and necessary interventions because of lack of resources. And in a high-income setting study, researchers found that 42.6% of low-risk women who were treated with oxytocin for augmenting contractions, they did not meet the criteria for labor dystocia, despite that the Partograph was used to identify dystocia. And also, it is worth noting that investigating whether birth attendants adhere to the Partograph in use is challenging. Even if it is used as intended, the standardized labor progression monitoring tool leaves little room for individual assessment and personalized management of labor. And some systematic reviews, including Cochrane reviews, they show limited or equivocal evidence that Partograph use improves the clinical outcomes like cesarean section rate or UPGAR scores. Overall completion rate of Partograph is also low, which diminishes their utility in clinical practice. The sections particularly related to the progress of labor and fetal well-being are better completed than the maternal condition monitoring. And even when abnormalities are recorded, there can be failure to act promptly, limiting the Partograph's effectiveness. Some practitioners in high-income countries consider it an unnecessary interference in clinical workflow, and positive attitude do not always translate into consistent use due to workload, availability, and organizational culture. There is no clear data on maternal satisfaction or quality of care improvement with Partograph use. So this is the cause and effect or root cause analysis of why there is difficulty in using the Partograph use. So there are so many procedure related or people related or policy related or place related issues. Commonly seen things are monitoring and supervision difficulty. No regular audits are being conducted on the use of Partogram. No written policy on using the Partograph. There is shortage of residents or nurses, and they consider that it is time consuming, and it got attached to the case sheet, but it's misplaced now. Printer computer is not working, so paper is not freely available. These are the reasons they say for not using the Partograph in all cases. Now, let's see what evidence says. So, effect of Partograph use on outcome for women in spontaneous labor at term. This was a paper published in National Library of Medicine in 2018. It suggests that training and context plays a key role in its effectiveness. So, continuous training is needed. And WHO trial in 1994 findings say use of a Partogram with an alert line reduced prolonged labor, sepsis, and need for oxytocin augmentation. It reinforced that Partograph's value is of very much important in low resource setting. And this is yet another study say that to assess the knowledge of Partograph during labor among the midwives in selected hospitals at Bhopal. This was the study published in IJTSRD in September-October 2024. The knowledge level of the Partogram among the midwives revealed 57.8, 63 they had moderate. So this study says that knowledge is very important for the use of Partograph. Implementation of Partograph in India's JSY cash transfer program for facility births, a mixed method study in Madhya Pradesh province, which was published in BMJ in 2015. It again says that implementation fidelity used in Partograph JSY program is very low. Successful implementation can result in improved quality of care in JSY program only if the potential moderators to its adherence, such as training, supervision, staff buy-in, and practice environment are addressed, so that staff finds a conducive environment in which to use the Partograph, and women find it beneficial to present early in labor. So all studies say training is very important. Healthcare professionals' adherence to Partograph use in Ethiopia. This was a study published in BMC Pregnancy and Childbirth in January 2020. Here it says only 32% of the health professionals completed the Partograph correctly. Gap in training and overburdened staff contribute to underutilization and misuse. Interventional research should be conducted to improve the current rate of adherence. This is yet another study, utilization of Partograph for labor management among healthcare providers in healthcare facilities in India, published in August 2023. It was a systematic review. It indicates that healthcare workers in most of the reviewed studies displayed inadequate knowledge, limited adherence to practice, and only moderately positive attitude towards the utilization of Partograph. Partographic analysis of labor by modified WHO Partograph in a tertiary care center, published in IJRCOG in 2022. It was a hospital-based observational study. And this study showed that it is highly effective in reducing both maternal and neonatal morbidity. It aids in assessing the progress of labor and to identify when intervention is necessary. It is effective in preventing prolonged labor, obstructed labor, and reducing operative interventions and improving neonatal outcome. Modified WHO Partograph in labor room, a quality improvement initiative to find out concerns, challenges, and solution. A paper published in October 2022. It was a quasi-experimental study. This states quality improvement approach has effectively improved adherence to Partograph use by solving the root cause of the concerns and challenges, such as regular training of healthcare professionals, making department policy, assigning checking authorities, and making triage areas. So all these studies say we need continuous ongoing training. So having seen what evidence says, what we have to do is ensure accurate and timely data entry to maximize the effectiveness of the Partograph, establish standardized guidelines for interpreting the Partograph, regularly review and update the Partograph to reflect changes in labor progress, use the Partograph in conjunction with other assessment tools to get a comprehensive picture of labor progress. As the evidence for existing Partograph is inconclusive in terms of clinical outcome, facility should adhere to national or local policies to guide the Partograph use. Health facilities should audit, which is very, very, very important. They should audit the Partograph to identify any barriers to use and to determine the most effective plan to overcome them. Labor monitoring tool should only be used following introduction of a comprehensive implementation strategy, which includes training of all healthcare providers and an easily accessible guideline for use. Thank you.
Mahalakshmi, thank you very much for finishing ahead of time. Thank you so much.
Thank you.
Next, I welcome Dr. Rekha Bharati.
Yes, ma'am.
Yes, Dr. Rekha
Yeah.
Bharati is the Professor of Obstetrics and Gynecology at Vardhaman Mahavir Medical College and Safdarjung Hospital, Delhi. And she has a lot of credits. And over to you, madam. Now we are going to talk about the way forward, the most difficult task of using the labor care guide.
Yes, ma'am. Just let me I'll share my slides again.
Yes.
Yes. I hope it's
Yes,
visible.
Yes.
Yes, visible, Rekha. You can proceed.
Yeah, so a lot has already been talked about the partograph. So what I'm going to talk about today is the new partograph, which is a labor care guide, also known as next generation partograph. So my previous speaker has already, highlighted the need for using partograph. So we know maybe, in other countries, they don't realize that it is required, but in our here in India we know that it is something which is going to be a paper should be there, because India has still not advanced that much there. Everything is documented on the computers, each and every step, so we are not able to do that. And the next person who's going to have a look at it, also it is also important for that person to know what the previous team has worked on. So with the labor care guide, I'm just going to describe what it is, why there was a need for labor care guide. This is regarding the partograph, the monitoring, which already has been talked about, and this is that modified WHO partograph which we were all using and very comfortable by using it also. So what was the need to modify this existing partograph? So this was, basically after this study, which had highlighted that these women may not have the progress of labor. It may not be same for all the women. So this Zhang et al, there was this landmark study in 2010. And why this study was important? Because the initial the curves which were made by the Friedman and they were followed by WHO also, they were based on very limited data. And this study by the Zhang actually was a multi-centric study which involved more than 60,000 women. So that is why, the more evidence came that what we assume should be the progress of labor in centimeters per hour may not be true for all the women. So this is basically the basis of starting the study. And then also WHO introduced in 2018 guidelines for positive pregnancy experience, the intra-partum guidelines. So just for the women to have this, positive pregnancy experience also, it was important to have another kind of a partograph which had various other components which were missing in the modified WHO partograph. So here, another thing was that when we looked at the cesarean sections, this is a study from Safdarjung Hospital. So it was realized that Robson group 1, 2, and 5, they were the major contributors. So the women, who were primary and didn't have previous cesareans were in labor, and they had cesareans for prolonged labors or delay in progression of the labor. So the number of these women were very high, and that's why the women who have repeat cesarean section also increases. So the labor care guide basically, as any other partograph, it basically monitors and there is a documentation of the progress of labor. But along with this, there is one very important component of offering supportive care. And then it also gives, reference thresholds, which are the alert parameters. So this, because when you are going by the alert parameters, the references which are next to where you are documented the progress of labor or maybe the well-being of baby and the mother, so you can always compare that whether this patient has crossed that threshold or not, so that you can avoid unnecessary intervention. Then finally, obviously, the audit and quality control, which is with every documentation that we are doing. So it should be initiated at 5 centimeters. We all had accepted this. Even with the modified WHO partograph, it starts at 4 centimeter. We were plotting at 5 centimeters because these recommendations have been there for a very long time. And then it can be used, at all the settings, whether it is primary, secondary, or tertiary care setting. The only difference is when we are using it at the lower level facilities, there should be referral facility available. And that's true for any woman who is in labor being monitored at a healthcare facility. So it can be used in all women. And as we know, in high risk women, we require additional monitoring and care. So that we were giving even when we were using the modified WHO partograph. So what happens here is that you assess the patient, you record your observation, you compare them with the alert parameters which are given. Then you plan the further management in consultation with the woman. So the woman involvement in her management also is very important here. So if we see the components of the labor care guide, so there is one column, the one section for identification, which was previously also there, but few columns have been added to this identification. Then extra section for the supportive care has now come up. Then care of the baby, as it was there previously also, just few things added to that. Care of the woman, labor progress, medications, and another column which has been added is the shared decision making. And one very important thing is that when you see on the right side, monitoring of the second stage of labor is also included. So this is the comprehensive labor care guide, how it looks like when you see it. And if you come on to the section wise, if you see on the top, you have all the identification parameters of the patient. And then there is one date which you write when the active labor diagnosis was made, means when you started plotting this partograph. Then also there is date and time for the rupture of membrane. Now, many a times, you may not know this time of rupture of membrane. So you can write here UK, that means unknown. And risk factors, this is one extra thing that is there for the patient's identification. If she has any risk factors like preeclampsia, diabetes, or she has had previous stillbirth, or anything which is a risk factor for the patient is written here. So the patient is identified as having any of the risk factors which can be there. So next column is for this is the time. So you write the time, and the time you can see the colon between. So the hours and the minutes, So if it is say 12:30, so you'll write 12 and 30. So this is the colon in between which divides the hours from the minutes. And this is the hours 1, 2, 3, 4, 5. So here we write the time when we start plotting. I'll show you one example that how it is done. Then section 2 is a supportive section, where if you see whether the woman has companion or not. So here what all can be written, either there will be companion, or she'll not have a companion, or she may deny she doesn't want to have a companion. So you'll write Y, N, or D here for the companion. Similarly, for the pain relief also, she may be having pain relief, and then if she requires not having pain relief, she's in pain and requires, then N would be written for not having pain relief. Similarly, for the oral fluids also, you have Y, N, and D. She may deny if she is in advanced labor and for that particular time she is not willing to take orally, then you will write here deny. But the moment you write N in any of these columns, they are the alert parameters, and you circle them either with red or with the blue pen, that is immaterial, but you circle to highlight that this is the alert parameter. Then babies section is more or less the same. The only thing is that you also write fetal heart decelerations. So there could be early, late, or variable decelerations. So it is basically advised that you start auscultating when the woman is having contractions towards the end of the contraction, and continue auscultation at least for 30 seconds after the contraction has gone. So you will be able to pick up the deceleration. So this monitoring is not by the continuous fetal heart monitoring. This is by the intermittent auscultation only. So you can know the variable deceleration, late and early deceleration also on auscultation of the woman. So that you will write here. So in case it is late deceleration, that even after the contraction has gone, the fetal heart, the decrease in the fetal heart is persisting, you write L here and you circle it. And then coming to the amniotic fluid, the same indication which we were using, I for intact, C for clear, M for meconium, B for blood. But whenever you write meconium 3+, so 1+ and 2+, if the fetal heart is okay, we know that we leave the patient, but 3+ is an alert parameter. So you have to circle that. And you know, whenever you are circling, means some decision has to be taken. Similarly, for blood stain liquor also, you circle that parameter if you write B or M3+. Now, this is another extra thing which we are writing here is fetal position. So whenever you do per vaginal examination, this is what you are going to write, whether it is posterior or transverse. For transverse, you always circle it. Similarly, for caput and molding also, 3+, if it is there, then you circle that parameter, means there's something wrong. Why should there be 3+ caput and 3+ molding? So that needs to be looked into. Then coming to this other section where you see the well-being of the mother, the pulse, systolic, diastolic, BP, temperature. Now this temperature you write when you take the temperature every 4 hourly, and for this also there are alert parameters written as it is for the pulse, systolic, diastolic, blood pressure. So low systolic or high systolic or high diastolic. Similarly, bradycardia, tachycardia. So these are the alert parameters. You know, up to 120, it's okay. But the moment you go over 120, you have to circle that. Then urine for proteins and acetone. So if proteins are 2+ or acetones are 2+, that is also one parameter. So we encourage women to pass urine. So whenever she passes urine, urine for proteins and acetones is done in that case. Then coming to the fifth, then there is a section of uterine contractions. So this is, you know, we were previously plotting uterine contractions and the cervical in our previous partograph also. So similarly, you plotted here, but we are not making any, boxes here. So you just write the number of contractions in 10 minutes the woman is having, and anytime, because patient is in active labor, if the number of contractions are less than or equal to 2, that is an alert parameter. Similarly, more than 5 is also alert parameter that you have to act in these cases. And duration of contraction less than 20 seconds or more than 60 seconds also becomes alert parameter. Then coming to cervical dilatation. So here, you know, we are not plotting it against the graph which is there. We are just writing it here. The same, we use cross to mark the contraction. So here also we are going to put a cross here. So in the time section, you know, when we have done PV, first PV, we'll put a cross wherever the contraction is. So I'll show you one, I've made one partograph to show you. So how it is marked there. Similarly, for descent of head, which we know will be seen on per abdomen examination. And this is similar to the previous one, that if you are given oxytocin, you write here how many units and drops per minute, or if you are giving in milli-international units per minute by the infusion pump, you're going to write it here. Any medicine that you give to the patient is documented here. And if you are giving IV fluids, that is also written here. So now coming to the next section, which is section 7, it is basically the shared decision making. So this is a new section which was previously not there. So here you do the assessment. So this assessment will be based on whatever alert parameters are there. And if everything is normal, you write there is normal progression. For plan, so now when you plan a patient's decision you take with whatever assessment we have done, we have to ask the patient, you know. So if we say that she's in pain, and that is an alert parameter, so we ask her if she needs a pain relief, if her companion is not there, whether she needs that. If she's not taking orally, why is she not taking orally? Just look into that, encourage her to take orally. If she is not having any position, but she's in the supine position. See here, I just forgot to mention one thing, that when we were writing here about the posture, we write SP if the patient is in the supine position, and for all other postures, whether it is sitting, left lateral, standing, walking, it is written mobile, MO. So it is only the alert parameter is the supine posture, for which we write SP. So if she is in the supine posture, we encourage her to change her posture, shift to left lateral, or if she wants to sit, stand, or walk around. And here the initials are put, the doctor or the person who's monitoring the patient in that particular time will sign here. So this is for 1 hour. Every hour you have one box written, which you will be filling up. So now this is a patient, you know, who is 28 years old. Her date of admission was 26 April 25, and this was her identification, UHID and IP number. And she is a second gravida, para 1 with 1 live issue, labor pains for 10 hours. I'm sorry for the spellings here, and leaking PV for 1 hour. The companion was not present when the patient was first seen in labor room. Pain relief was not provided. She said she needs pain relief. She had taken 1/2 glass of juice 15 minutes back, and she was resting in the left lateral position. So if I have to mark it here, I'll write the name, age, or UHID, IP number. And this is the active labor diagnosis. So today she is diagnosed in active labor, so that I have written here. Then labor onset was spontaneous. She had spontaneously gone into labor. So spontaneous is written here. Her parity is here. She ruptured her membrane on 26th, 1 hour back. So I was examining her at 6 a.m. So 5 a.m. she had ruptured her membrane. There were no risk factors. So this has been documented. And if you see for the companion, there was no companion N, and it has been circled. Pain relief also, there is no pain relief. This should also have been circled, that she does not have a pain relief. And oral fluid she has taken, and she is in left lateral, means she is in mobile position. So that is MO. And then her fetal heart rate, this I'll show you. So this is her next parameter. If you see pulse, BP, temperature, and this is her per abdomen examination, term size, uterus, cephalic, 4/5 above brim, fetal heart 140, no deceleration, uterine contractions 3 in 10 minutes, duration of each contraction 30 seconds. See, this we were anyway plotting in the previous partograph also. So just the way we are plotting has only changed. And on PV examination, she was 5 centimeters in LOT position, and the station of the head was -3. And membranes were absent, lipo was clear, there was no molding and caput. So fetal heart monitoring 140, there are no deceleration, it's a clear liquor, but it is in LOT, so this T has been circled here. So similarly, if you come to the next thing, which is the meconium color is clear, fetal position, caput molding is not there, pulse, BP, everything has been written. Her urine acetones and proteins, they are negative, so that is mentioned. She's getting 3 contractions, 30 second
Sorry
each
to interrupt, Dr.
contraction,
Rekha.
and her cervix is 6 centimeters dilated, and head is 4/5 above brim, which has been marked here. We did not give her any oxytocin. She required pain relief, so injection PCM was given. But before that, assessment was done that patient required pain relief. It was discussed with her that what kind of pain relief she requires. So it is not always the pharmacological pain relief. It can be a non-pharmacological pain relief also, in the form of back massage, breathing exercises, or whatever the patient has been told about in the antenatal period. So that can be there. So this paracetamol was given at that time. See, in our hospital, we do not have a facility for epidural, but where they have facility for epidural, you can discuss with patient whether she needs it now or she wants to delay. And then the initial of the doctor was done. So similarly, you know, this patient was monitored, and all these alert parameters which kept appearing. So every 1 hour, we were asking her for the companion. The fetal heart rate was monitored every half hour. Now she is a low risk patient. Had this patient be a high risk patient, and we require to monitor fetal heart more frequently, say every 15 minutes. So I don't have any column to mark it every 15 minutes. So whenever I mark it after half an hour, I'll write the most, the one which I want to highlight. The fetal heart that I want to be highlighted would be
Sorry to
written
interrupt,
here.
Dr. Rekha.
Yeah.
Time is up. Time is up.
Okay, sorry. So this is, you know, how we plotted, discuss it with the patient, and the second stage also is here. So this is how it is. This thing. So it is obviously not a substitute for good clinical judgment, and you have to see the individual woman's basically progress. So this is, our study on labor care guide that we did, and I just wanted to highlight that cesarean delivery rate between the women where we use labor care guide and where we use the our WHO modified photograph was significantly different. Like it was significantly lower when the labor care guide was used. And if you see that the learning curve, it took 6, because there is a learning curve for this, but around 7, filling up of 7 labor care guide to shift it from very difficult to neutral, and around 2 to 3 to convert from neutral to easy. So this is what I wanted to highlight in this. And one thing, but I just want to show one thing here in this Partograph. If you saw the one which this one. So this patient was 5 centimeters. After 4 hours, she was again 5 centimeters. But if you see the alert parameter, she was not 6 or more than 6. So she was, within the expected dilatation. She had not progressed, but that was expected, that there was nothing to worry about. No need to, further increase the contraction and think why she is not progressing. So she was again monitored after PV was done after 4 hours, and she was found to be progressing. So this is one benefit of these labor care guides which is there. So thank you so much, and I'm sorry I exceeded the time, but I thought there are few things which I wanted to highlight in this.
Thank you so much, Dr. Rekha.
Yeah.
Sampath madam, can you introduce?
Yes, now we will introduce Dr. Muralidhar Pai, who will be in a position to tell about what are all the advantages with the previous and the present. Can I have the CV of Dr. Muralidhar Pai, Chitrakala? Pai needs no CV, but still for completion, he is the Dean of Sikkim Manipal Institute of Medical Sciences, and 37 years of academics, 25 awards, 15 international fellowships, 207 publications, 3 textbooks, and 835 guest lectures. Of all this, he is a good teacher, and he releases many videos with the particular topics. Yes, sir. Pai, sir.
Yeah, thank you, Dr. Sampath, for inviting me for this very, very interesting and important webinars that you have started. I congratulate you for this. Vivadham says that it is a controversy, as I understand. But of course, without controversy, there is no science. Science is always trying to find out the truth, eternal truth. Well,
Yes, sir.
let me jump into this assignment that you have given me. WHO labor care guide, my verdict. Well, let me clarify right in the beginning. To give the verdict, I am neither a judge nor an authority on labor. However, I consider myself as a moderator who believes in prudence and common sense. Right? Before
Yes,
I go on, I congratulate both Dr. Mahalakshmi and Dr. Rekha Bharti for wonderfully explaining both the old partograph, WHO partograph, which was called modified WHO partograph, and the new labor care guide of WHO 2020. They have beautifully brought out the problems in both of them, as well as the advantage of both of them. Especially, I appreciated Dr. Rekha in her initial lecture explained what was the need of a new partograph when the old partograph was doing wonderful job. Let us first understand why partograph in the first place, whether it is old or new. In fact, there's no difference between them on the face value. That is, both of them are a piece of paper, which is A4 size paper, and which has got certain parameters to be noted by the labor caregiver. Now, you may question, why should we note? Some of the affluent countries say that it's an interference, but that's not fair. We are living in an era where you have to document everything. In fact, we tell our PGs that if you don't document, you have not done. So documentation is very important. And there's nothing extraordinary that we are doing in both the parthographs. We are monitoring anyway. This monitoring has been time immemorial. Only the duration of monitoring, type of monitoring, and the parameters and the thresholds for reference may have slightly changed here and there, but monitoring has been going on. And all that the partographs are requesting the doctors is to document what you have monitored so that at a glance you can see whether things are going all right or not. And if things are not going all right, then you have to intervene and you have to take appropriate action, all because we want to give a very happy experience to the lady who is delivering as well as to her family members. That is the main issue, right? So Dr. Rekha told the old partograph was slightly stricter in the sense it expected all women to behave in the same pattern. We know it is very difficult to understand women, right? So very difficult to understand how they labor. And there are so many different patterns of labor. So expecting all women to follow a very strict regimental alert line and action line was unfair. And especially when Zhang said nothing much happens up till 6 centimeters, or at least it is so variable, it is only fair to start really documenting after 6 centimeters. So that's how the new labor care guide was born. Now, I am not here to say which is better or which is good, whether something should be discarded or whether something should be promoted. It is an eternal journey. After a couple of years, they may come up with another partograph which may have rectified the problems in the new labor care guide. So let me now start my sort of analyzing the new labor care guide vis-a-vis the old partograph. Now, what does WHO Labor Care Guide, I would call it LCG 2020, say? It's a tool that aims to support good quality, evidence-based, respectful care during labor and childbirth. I'm sure all of us agree with that. So there is not anything for me to say whether it is right or wrong. Irrespective of setting, this is very important. Whether you are in the high class setting or a low resource setting, it should be followed. You can't say we are a corporate hospital, we don't have to follow this. It is only for primary care center. Not like that. It has to be followed in every hospital, in every labor room, and for a positive childbirth experience. So naturally, as Rekha said, it's a next generation partograph. It's not something totally different. It is just a modification of the old one. What are the guiding principles? The labor and childbirth should be individualized. I have purposely increased the font size, change the color, and change the font pattern also. That is very important. Every woman is different, so it has to be individualized and it should be woman centered, not the doctor centered. So I agree with that. So whenever you see a tick mark, green tick mark, that means my verdict is I agree with that. No intervention should be implemented without a clear medical indication, not the urgency of an obstetrician to catch a flight. So let me finish this with the cesarean section. So it should be with a clear medical indication. Again, a green tick mark from me. Only interventions that serve an immediate purpose and proven to be beneficial should be promoted. Again, another tick mark. So a clear objective that a positive childbirth experience for the woman, the newborn, and her family should be at the forefront of labor and childbirth care at all times. I agree. So what are the guiding principles? Again, as Rekha said, I'm just reiterating: emotional support from a companion of choice, effective communication by staff, pain relief strategies, anything pharmacological, non-pharmacological, regular labor monitoring documentation of the events, oral fluid and food intake, mobility, pre-established referral plan, and continuity of care. So if this batch of PGs finish, the next batch of PG should be able to take over from there or whatever. So ultimate goal is a respectful labor childbirth care. I totally endorse this. When to initiate? Rekha has already beautifully told it is neither 4 centimeters nor 6 centimeters of Zang. They said it is 5 centimeters. But here comes the caution from me, my verdict. One should not neglect latent phase, though it varies widely among women. It is said it may wide between 8 hours to 28 hours, sometimes even 48 hours, 2 days. She may be in pain. Patient is frustrated. She will force you to do cesarean section. But you have to be very sure that everything is under control. How do you monitor in the latent phase? Monitor the same parameters: maternal pulse, BP, uterine contractions, and fetal heart rate. Of course, you will also do PV once in 4 hours to see whether there is any effacement, dilatation, or taking up of the cervix. Then, what is the caution? Only thing is that unless there is a gross deviation or let's say fetal distress, don't interfere. What do you mean by don't interfere? There is no need to do a ARM or start oxytocin unnecessarily in the latent phase. So this is my verdict about the starting at 5 centimeters and not doing anything before 5 centimeters. Now, the next important issue in the new labor care guide is they said that cervical dilatation of 1 centimeter per hour is unrealistically fast in some women. I totally agree with that. Second, it is inaccurate to identify women at risk of adverse birth outcomes. Just because she crosses the alert line, you don't have to jump into a cesarean section. Even there also, in the old partogram, they said you have to wait for another 4 hours, reassess, and final action line was after 4 hours to the right of the alert line. But that also is very fast. So I agree with this statement that hence not recommended for this purpose and nor for identification of normal labor progression. I agree with both sentences. But now coming to the duration of active first stage of labor. In the old partogram, what did we say? It started at 4 centimeters and the expected rate of dilatation was 1 centimeter per hour. In other words, we expected the lady, once she entered the active phase, to deliver within 6 hours. This is too rigid. Now, what does the new labor care guides says? You start at 5 centimeters, but you give a good 12 hours in the first labors, that is primigravida, and at least give 10 hours in the subsequent labors. This looks too relaxed. Yes, as I initially stated, I am a moderator. Extreme views are not always good. Extremists are not good, isn't it? So you have to be commonsensical. You have to be prudent. So what is my verdict on this? Should I wait for 12 hours in primies or should I wait for 10 hours in multis or should I take some decision within 6 hours? My verdict is one should not blindly wait for 12 hours to take the decision for active management. It's not that you waited 12 hours, you went for a coffee or a dinner and you came back and nothing is happening, then you panic. What are the active management things we have? ARM plus oxytocin, instrumental delivery, or an emergency section. So how to do that? Do not go only by cervical dilatation, though that is one of the very important issues both in old partogram as well as new labor care guide, but that's not the only parameters. In fact, in the new labor care guide, for every parameter, they have given a action or an alert. That's why I like it. It's not just based on only cervical dilatation. There are so many other parameters. Take decision holistically. We always say holistic decision. Just because cervix is not dilating as per rules, don't go and jump. Or just because the labor care gate says you can wait 6 hours in 5 centimeters, don't blindly wait for 6 hours. In between, if there is a problem, if there is, let's say, meconium stain, if there is fetal distress, if there is incoordinate uterine contraction, please take action. What is written there is the maximum that you can wait. That doesn't define the minimum. That doesn't overrule. If there is any problem, overlook it. So that's why I said prudence is very important, common sense is very important, alertness is very important. What WHO labor care guide gives you is the maximum. Don't go beyond that. That does not mean that sleep till that time. You have to take action judiciously. Now, coming to second stage of labor, again, labor care guide is the only one which talks about second stage. The old partograph does not talk about second stage. That's why I like it. But again, here it gives 3 hours for primies and 2 hours for multis. In fact, in Manipal, we used to pull up the PG, shout at them for waiting for 3 hours in the periphery. They used to have peripheral postings in primary care centers. They brought the patients after 3 hours and they used to get a nice shouting because they simply probably waited. So my verdict here is, though labor care guide says a maximum of 3 hours for primary and a maximum of 2 hours, again use this as the maximum limit. That does not stop you from taking action earlier. Again, my sentence goes, one should not blindly wait for 3 hours in primary and 2 hours in multi. Take decision on instrumental delivery or emergency LSCS earlier. For example, if you monitor every 5 minutes, that's how we have to monitor the FHR in second stage. If there is fetal distress, now corroborate that with meconium staining of Leica, corroborate that with the late deceleration. If there is deceleration for lasting for more than 2 minutes or even 3 minutes, don't wait for 3 hours now. If there's a big caput, if there is pathological molding, don't wait for 3 hours just because labor care said. See, this is like somebody Karnakri, there was a lady called Karnakri. She would just do the opposite. So just because you are saying wait 3 hours, just to defeat the labor care guide, don't say I waited for 3 hours and I lost the baby and I lost the patient. That is a very bad attitude. So we are in a habit of abusing and misusing anything that is given to us. We are not using our balanced mind. So use a balanced mind. That's what I'm saying. So again, I don't want to explain this. Bharti has nicely told, Rekha has told nicely. Only 2 things added. I like them. One is supportive care. Other one is shared decision making. So these 2 are the good ones. Right? I have put tick mark for both of them. Now, monitoring to action. To ensure that systematic and consistent application of labor care guide, health providers are encouraged to use following approach: assess, record, check, and plan. So I totally agree with that. Now, axis line and alert line, these are there. I agree with this alert line, which is given for every single parameter. Now, I don't want to explain this. This has been explained. So I agree with the total supportive care. Second one, I agree with the total pain relief plan. Third one, baby, as Rekha said, there's no change at all. It's all the same thing. I totally agree with this. It's just that you have to write nicely. As far as the fetal position, caput, molding, I totally agree with this. Nothing to worry about this. As far as the heart rate, totally agree. Now, for the woman, urine, acetone, totally agree with this. Nothing to object. Pulse, BP, temperature, urine, nothing to object. Totally agree. Now, labor progress, again, when you talk about the contractions, nothing to object here. Totally agree with the number of contractions per 10 minutes, duration of each contraction, everything. Now here, this is the most important slide, which totally surprised everybody in the new labor care guide. This is the most controversial area of the new labor care guide. So I will spend 2 minutes extra minutes in this. This is the one which, when you look at it, you will get surprised. Can I wait for 6 hours in 5 centimeters? Can I wait for 5 hours in 6 centimeters, 3 hours in 7 centimeters, and 2.5 hours in 8 centimeters, and 2 hours in 9 centimeters? And in second stage, can I wait for 3 hours in nullipara, 2 hours in multipara, This sounds like a sensational statement. But again, I have already explained this. The total duration of active phase is 12 hours. Don't blindly wait for 12 hours. Now, 5 centimeters, don't blindly wait for 6 hours. 6 centimeters, don't blindly wait for 5 hours. I am simply repeating this because to reiterate the point. Don't blindly wait just because the top line is given or the maximum duration is given. So, what is my verdict? My verdict is the same as I told before. One should not blindly wait to take the decision for active management. Do not go only by cervical dilatation. I'm repeating this many, many times. Take decisions based on other parameters also. For example, FHR you are doing every 15 minutes and first stage every 5 minutes. Contractions, caput, and the molding, everything is important. If there are any incoordinate uterine contractions, if there is no cervical dilatation proper, or if it is hanging loose, take action based on those things. As far as descent is concerned, both old and new didn't have anything to say, so I agree with that totally. Medication, nothing new, nothing to object, agree. Shared decision is a new thing. It's a wonderful thing. All decisions should be taken discussing with the patient, also the plans. So whether it is continuation of routine monitoring, diagnostic additional tests, or procedures or cesarean, take patient into confidence. Finally, women should be involved in all the decisions. I totally agree. So to summarize what I am saying, the WHO recommendations 2020, first stage, recommendations are auscultation every 15 minutes. Agree. PV at intervals of 4 hours. Agree. Epidural anesthesia where available. Agree. Parenteral opioids or any pain relief. Agree. Relaxation and manual techniques for pain relief. Totally agree. If husband wants to
Some net issues, I think, sir.
Hello,
Hello,
Muralidhar sir.
Sir, I think the
Some net issues, I think.
net connection problem.
Only few minutes.
Yeah.
Connect to the phone. You can call him, no.
Hello. I'll just call him and he'll log in again.
ஒண்ணுதான் ஒரு 5 நிமிஷம் தான்.
Almost over the sir and the final தான் சொல்லிட்டு இருந்தாரு.
Yeah, I had lost the internet connection.
Okay,
Oh,
yes, sir.
I'll come back.
Welcome back, sir. Thank
Yeah.
you.
Yeah. I'll come back.
Yeah.
So you are looking at me very dark. Okay. So I was at this slide. Am I right?
Yes, sir.
Yeah. So I'm just having couple of slides only. I'll wind up. So the WHO recommendations, auscultation every 15 minutes. I totally agree with that. And PV at intervals of 4 hours. I agree with that. Epidural analgesia. I agree. Parenteral opioids, fentanyl, dopamine, or pethidine, or any of the methods. I agree. Relaxation and manual techniques for pain relief. If the husband wants to massage the back of the lady, I agree. Maternal mobility. I agree. Oral fluids. I agree. So totally agree with these recommendations. But now coming to not recommended on admission, I have certain reservations. For healthy and women with spontaneous onset, routine clinical pelvimetry is not recommended by WHO, but I put a question mark because we in Manipal believe in doing this, because why give the lady worse of both worlds? That is, Suppose there is a CPD, better to take her up first section straight away rather than midway through the labor, realizing that there is a CPD, that's why there is no descent, and then take her for cesarean section. I hope others agree with me. Routine admission CTG to assess fetal well-being is not recommended by WHO, but I put a question mark because it's a good habit. Better to know the baseline so that you know whether there is any variation later on. Perineal pubic shaving prior to giving vaginal birth, I leave it to the local practice. Enema for reducing the use of labor augmentation. Of course, for labor augmentation, we are not giving enema, but we are giving enema to make sure that in the second stage, there is no soiling of the perineum. Again, I leave it to the local practice. I don't have any verdict on that. Routine vaginal cleansing. Again, I leave it to the local practice. Intervention for cervical dilatation of less than 1 centimeter per hour in active stage of labor. I agree with the WHO. There is no need to intervene. Right. So as far as these recommendations, which are not recommended, continuous CTG, I have a question mark because I believe that in high-risk cases, it is better we go for continuous CTG monitoring. IV fluids to shorten labor, nobody gives IV fluids to shorten labor, but it is better to keep a IV line should there be a need later. I agree with this, not to shorten the labor. Active management of labor, I put a question mark because it is always better, suppose there is tardiness, to go for ARM and start oxytocin and maybe use an instrument in between in the second stage, of course, not in the first stage. Routine or early amniotomy plus oxytocin is not recommended. I agree with that. Oxytocin for women with epidural analgesia, not required. I agree with that. Antispasmodic agents for prevention of delay. We used to give, earlier we used to give what is called epidocin, and then there was drotaverine, but it is not required. I agree with WHO. As far as recommendations for second stage, auscultation every 5 minutes, I agree. Both the other birth position, individual women's choice, including upright position. I know upright position is little difficult for us to handle, but whatever comfortable position she likes, I agree. Pushing, encouraged to and supported to follow their own urge to push. Yes, this is very important. Follow their own urge. You know, we should not be asking them to unnecessarily push when she's not feeling like pushing. But when she feels like pushing, that means when the head is on the perineum and it is pressing on the rectum, there's a natural urge to push. And at that time, if you encourage, she pushes better. Yes, I agree. Preventing perineal tears, you have to give support. Nobody can object for that. What is not recommended in second stage is a routine episiotomy. Nowadays, we don't give routine episiotomy, but it is required, don't hesitate to give episiotomy, especially when you are using instruments. And if it's a rigid perineum, a previous scar, better to give episiotomy. That's what I feel. Application of manual fundal pressure is no for me. I agree with WHO. Third stage is concerned uterotonics for prevention of PPH. I agree. It could be any one of them. And delayed clamping is now the new thing. I agree totally. And controlled contraction, of course, I better agree. And what is not recommended is routine massage is not recommended. I agree with that. Thank you so much for this opportunity. Was I there?
Yes, sir. Fantastic, sir.
Yes.
Okay, okay.
Yes,
No,
Vijaya.
because I thought
Yeah. Sir, what to say, sir? Clear-cut recommendations and judgment more than the Supreme Court judge, because everyone is confused about this labor care guide and partogram, still hesitant to use the labor care guide. And I think it will take us some more time. And as Rekha said, needs more training and more critical evaluation and audits. That will go a long way. And so nice and perfect finish, like a
Yes, sir.
cricket match. And in time.
No,
and
no,
some-
he told he is not a judge, moderator. So individualize the case.
Okay. Yeah, nice,
Fantastic,
very
sir.
nice topic selected by Sambat, and it is a real, instead of a lecture and CMA, this is really good, sir, for the PGs for their exam going. Very good, sir. Thank you so much, sir.
yeah. What I want to finally say is that what I want to finally say, whether you want to follow the old WHO partograph or the labor care guide, you must insist one of them should be followed.
Yes.
You
That's-
follow either of them. Yeah, one of them should be followed, and it is in our own interest, because the documentation is very important. The only thing is that we cannot be very rigid on any side. We cannot be relaxed also. We cannot be rigid also. As I'm a moderator, always go to the moderate view. Extreme views are always bad.
Thank you, sir. Done your job. Fantastic.
Thank you.
sir. We will come to Shillong
Thank you so much.
to see your hospital.
No, not Shillong. I'm in Sikkim.
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 Oh, Sikkim. Yes, sir. Yes, sir. Sikkim. Sorry.
Shillong is totally
We will
different.
Sure,
Yeah,
sir.
please.
Yes.
I welcome all of you from the hot weather of Chennai or South India right now. Please
Yes,
come
sir,
here.
yes,
You can
sir.
see the
Yeah, very
beautiful
nice, sir.
hills
Very
behind
nice.
me.
Yeah.
Yeah.
Thank you
Okay.
so much, sir.
Thank you so much. Yeah.
Meena
Yes,
is
sir.
there to give vote of thanks.
No,
Thank
formal
you
vote
so
of
much,
thanks by
sir.
Dr. Vijaya.
Vijaya, madam.
Yeah, on behalf of Obstetrics and Gynec Society of Southern India and along with the Oxy Medical Education Committee, we would like to render our heartfelt thanks to our dear President Sambat ma'am and ever young coordinator Karpagambal, and also for all the speakers Mahalakshmi and Rekha and Murlidhar sir. This is a very, very nice and usually it is all knowledge sharing session and what to do and what not to do and when to do, clear cut guidelines. Thank you so much on behalf of Oxy.
Thank you, sir. Thank you, Vijaya.
Thank you very much.
Thank you.
Yeah, thank you,
Thank
ma'am.
you. Thank you. Bye.
Thank
Thank
you,
you,
Dr.
Sambat.
Sampat
Good.
Kumari, Dr.
Bye.
Vijaya, and Dr.
Yes.
Karpa. I'm so obliged for your having me here, and thank you so much. It was really a very wonderful session. I totally enjoyed attending it. Thank you.
Thank you. Thank you
Yes,
so
sir.
much.
Good night
Thank-
to all.
Yeah,
Good
bye.
night.
Thanks and bye.
Thank you. Thank
Thank you, madam.
Thank you, madam. Thank you.
Thank you, Meena.